بسم الله الرحمن الرحيم. الحمد لله وحده والصلاة والسلام على من لا نبي بعده. أما بعد, Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Zakaria Guennoun, consultant in diagnostic radiology. Welcome to the essential imaging guide for renal infections. Knowing what to look for and where is really important. Here's a quick summary on how this course is structured. We will talk briefly about the imaging modalities, and then we will describe the gold standard of renal infections, which is acute pyelonephritis. We'll move on to the big three life-threatening infections, which are pyelonephrosis, emphysematous pyelonephritis, and renal abscess. Then we will list the four chronic and mostly unique cases, which are chronic pyelonephritis, xanthogranulomatous pyelonephritis, genitourinary tuberculosis, and hydatid cysts. And finally, we will not forget to mention the three critical non-infectious mimics, which are renal infarct, renal vein thrombosis, and cortical necrosis. So, our diagnostic sequence starts with modalities. Ultrasound is first line for screening. It is radiation-free and checks for hydronephrosis and abscesses. Contrast-enhanced CT, CECT, is the gold standard for full extent and complications. And MRI is reserved for contrast allergy or renal impairment, offering superior soft tissue detail. We start with the gold standard of renal infection, which is acute pyelonephritis. On CECT, look for wedge-shaped or rounded hypoenhancing areas. These are perfusion defects. Note the accompanying perinephric fat stranding and thickening of Gerota's fascia. On ultrasound, often subtle, it may show localized areas of increased or decreased echogenicity. And on MRI, the affected zones will show poor enhancement with a high signal intensity on T2 and restricted diffusion. We move on to the big three life-threatening infections. These three emergencies are killers, demanding immediate recognition and intervention. First one, pyelonephrosis, which is pus under pressure. Ultrasound will show dilated collecting system with mobile debris and low-amplitude echoes, possibly with layering pus. Kidney is often hyperemic. CECT will show dilated, thick-walled, hyperenhancing collecting system filled with intermediate or high-density pus. It also may show cortical thinning. And MRI will show fluid-fluid layering, which may be seen on T2-weighted images. Second life-threatening condition is the emphysematous pyelonephritis, which is a necrotizing infection with gas in the parenchyma, often seen in diabetic patients. CECT is the main modality here, which confirms intraparenchymal gas and its extent. Look also for associated fluid collections and perirenal extension. Ultrasound will show non-dependent echogenic foci with characteristic dirty shadowing or ring-down artifacts. The differential here is emphysematous pyelitis, which is less severe because gas is confined to the collecting system, meaning only pelvis and calyces. And third life-threatening condition is the renal abscess. On CECT, you have round or geographic non-enhancing fluid collection with a distinct enhancing rim and surrounding inflammatory changes. Gas inside this fluid collection is highly suggestive. On MRI, complex cyst appearance with strong diffusion restriction and high signal and T2-weighted images. Now let's talk about the four chronic and mostly unique cases. We begin with chronic pyelonephritis. On IVP and CT, you have deep cortical scars overlying deformed or clubbed calyces, often with upper pole involvement, asymmetry, and contralateral hypertrophy. Blunted calyces from papillary retraction are key. The DMSA scan is useful for detecting renal scarring. Second chronic entity is the xanthogranulomatous pyelonephritis. On CT, you have a non-functioning enlarged kidney with an obstructing stone, often staghorn, in a non-dilated pelvis. Look for low attenuation lesions replacing the parenchyma and possible perinephric extension. Third one is genitourinary tuberculosis. On CT and IVP, you have a calyx stem stenosis leading to hydrocalyx, cavitation, and eventual puaty kidney, caseous material calcification. Also look for ureteric strictures and a contracted bladder. And last chronic entity is the hydatid cyst. On ultrasound, it is anechoic with well-defined margins, sometimes showing the water lily or spiral signs or falling snowflakes. On CT, you have thick or calcified walls, multiloculated structures, or low-density daughter cysts. We finally move to the critical non-infectious mimics. Always consider these life-threatening non-infectious emergencies which can mimic pain and fever. First one, renal infarct, which shows wedge-shaped hypoenhancement, but the cortical rim sign, preserved subcapsular perfusion from collaterals, favors infarct in 50% of cases. Look for the flip-flop sign, hypoenhancement early and hyperattenuation late. Second one is the renal vein thrombosis, which shows enlarged kidney, delayed function, persistent opacification of the cortex, and a filling defect in the vein lumen on contrast. And finally, cortical necrosis. Look for the reverse rim sign, which shows hypoenhanced cortex with preserved enhancing medulla. Master these imaging features and they will significantly improve patient outcomes. Thank you.